Hey guys, Don here. Welcome to Podiatry Practice Mastery, where I'm trying to help you get to the $1 million mark and beyond. I want to kind of talk a little bit today about my day. I call this the million dollar minute, which kind of helps you to get what's helping me to get to the $1 million mark. And I want to just everyone to, once again, I want to just help everyone get there. And I just want to share. I just got my numbers back from October, and so it's October numbers back. We're in the middle of November right now, but I did actually beat the $1 million mark, like right now, already in October, so that makes me feel good. So then it's probably going to be slightly over $1 million for the year in my personal production. So let me kind of share what worked today in the clinic. So my first patient was a patient that came back after 6 sessions of shockwave. He had the insertional Achilles tendinopathy, and he came in like an 8 or a 9 out of 10, and he's down to like a 1 or 2. Now, he was complaining a little bit, but I'm like, for 1 or 2 and for insertional, he's doing much better. So I did an ultrasound today on him, and then just the office visit. So he'll follow up as needed, so no follow-up. Just a reminder, kind of what I try to do is I try to either optimize the high-value patients or reduce the low-value patients. And I think sometimes reducing the low value is by either booking them all together or not seeing them back or double booking them. So I've been kind of thinking a little bit more about that here. Next patient was a patient with plantar fasciitis. And so you'll hear me repeat a lot my plantar fasciitis visit 1, which basically is an x-ray, level 4 visit due to my meloxicam that I give them, and then my Pelto special, which is always the night sprint, the foam rolling, and the morning stretch. And then all of these come back at 3 weeks. So that's kind of like my plantar fasciitis and Achilles tendinitis. Most of the itises, they get that same thing. Another patient that was here for a follow-up arthrodesis. She's doing well. If I could do it over again, I probably either wouldn't see her back again, but I had to because she had a little dehiscence, or I would double book her, and she was not double booked. So I think probably double booking next time would make it a little bit smarter. I got the x-ray out of it, but she's still within the post-op window. Other patient here was a patient that came in for a second opinion due to a second digit fracture. Basically was being treated by the primary care and urgent care, and they just want to be reassured. So the benefit to that is I got the office visit, but I also got the fracture code for that patient. Other patient, another plantar fasciitis number 1, which I just went over before. A patient that came in today for an orthotic follow-up, they're doing well, but they also had some lymphedema. And so what I've started to do, on my little notepad in my pocket, I'm keeping a list of lymphedema patients because I'm wanting to start to do these these compression garments by Amerix, because you can now do 3 compression garments per extremity every 6 months. So I think it's going to be a good addition to the practice. So I'm starting basically a wait list in my pocket. So I talk to patients about it, discuss it, but I'll call them when we start to do that. Another patient for EPAT number 1 for plantar fasciitis. A Lamisil booster appointment, which basically is my second Lamisil appointment where I give them a booster dose, so that's medication management, which bops up the office visit. And then that was the morning. Then the afternoon, there was a patient, interesting, he's going to have some knee surgery, so he's all paranoid about his foot. He's got a skin rash. The skin rash wasn't getting better with some amlactin, so I was going to have them try like a regular lotion first, but they were kind of concerned about surgery. So what we did is we did 2 2-millimeter punch biopsies on this lesion. And then he also complained that on the lateral side of the 4th digit, he had a kind of a painful area. Now, I've already done an exostectomy on the medial 5th digit, and now he wanted one on the lateral 4th digit. I probably should have done both at once. I don't normally do 2 exostectomies in the office, but we're going to set up that for a future date when we go over the biopsy results with the patient. Another patient that was a new patient, she was here for plantar fasciitis, got the whole plantar fasciitis number 1 in my Pelto special, but she also wanted orthotics. So we did orthotics visit 1. I don't normally do orthotics visit 1 for patients, but she had them in the past, and she had a lot of other midfoot arthritis and other issues that would make her a good candidate for those. A patient as well came back for a cyst follow-up that I aspirated. What I think is in the future for cyst aspirations, I'm not going to have them come back because it was looking fine. I'm just going to have them kind of come back as needed. Also, there was another patient that came in for a matrix follow-up in the office, and the matrix was doing well. And I usually do a 3-week follow-up for the matrix. But then this patient also had some tinea pedis, so I was able to do a topical antifungal for this patient and make that into a medication management office visit for the matrixectomy, which made it a lot better for me and for the patient. Another patient came in after having orthotics for a long period of time and got another pair of orthotics because his current ones were just a little bit old. He is a financial planner, and he came out of state to see me. And what I did with him is I said, we can just send these to your house because he has had them previously. And so we're just going to send them to their house. So we have a kind of a concierge like shipping fee where we can ship it to the patient, and we charge them for that shipping fee. So he's going to be happy about doing that, so he doesn't have to come all the way from Rhode Island to get those. And so sending it to them. So I think there's something to be said about making things convenient for patients if they don't want to come in or if they want to do a virtual appointment. I think many patients, they like that approach. And this guy, I had a really good rapport with him. He was actually knows a lot of people and has read everything from the person I get coached by, which was Dan Sullivan. So we had just really a good time connecting. I like financial planners are some of my favorite people. Next patient was a patient that came in for bilateral bunions, and we were kind of treating that. They did a really good job. They got correct toes, they got anatomic shoes. I usually recommend Topos or Ultras, or we sell Lems in our office. But she also had some equinus, so then we did the Pelto special for the equinus today. So she got the night splint, the foam rolling, the morning stretch, and stuff like that. And so that was a way of adding an office visit to like a bunion follow-up. Another patient that came in for first MPJ pain had a cortisone injection about 3 months ago, continued pain, so I did another injection. She had a little exostosis on the dorsal first met head, and so we talked about possibly doing like a little in-office exostectomy because her bunion isn't all that bad, and it might be that exostosis that's bothering her instead of doing these cortisones. We also talked about doing orthotics in the future. And then also there was a patient that came in who had been on terbinafine for like 9 months or like 3 rounds and didn't really get better. I wish I would have learned probably after the first round, but I don't think I did. And then she came back, but she had a really, really thick nail that was onycholytic, and she trimmed it back. And I don't find those ever reattached. So what I did for her is I did a nail avulsion, and I also put her on diflucan. So I usually do terbinafine first, and if that doesn't work, I'll put them on diflucan, and then if that doesn't work, I'll usually put them on Sporanox. So I kind of have that route of putting them on different levels of these medications. And then the one of the last patients was a patient that came in for Cariflex. So I sometimes don't think Cariflex is worth my time. She had her own kit, so she just paid for the Cariflex. But I think it does make them happy. She also was here for a Lamisil follow-up, so I gave her a new prescription for Lamisil, so we were able to get to office visit out of that. I guess, and there was one other patient that was here for the second toe fracture. I guess the takeaway from the day, for those that listen to the end, I am not a bragger, okay, but I want to help you get your practice to the $1 million mark. And I think my best month ever this month. I billed, and what I brought in was $139K. So usually I say to get to the $1 million mark, you need to bring in $80K per month, pretty much consistently every month. And the way you do that is you have 20 patients a day and bring in about $200 per patient. So those are kind of some numbers to think about. So anything that's under $200, you probably should either be double booking or not seeing. Everything that's over 200, you should be trying to do that all the time. So hence, when I said Cariflex really isn't worth my time, that kind of brought in 125. But unless I had the office visits on top of that, it wasn't really worth it. So I'm here to kind of help you bring your practice to the next level. You can go to podiatrypracticemastery.com/audit if you want to do like an audit of your practice of what's working for you, and I'll give you some audio feedback in like a podcast version such as this. Okay, until next time, thanks.